I like to begin with this number. The United States this year, at the end of the year, will have spent $2.8 trillion on health care. I know a lot of you are very, very well educated. You probably have a lot of experience with millions. Maybe even one or two of you have personal experience with billions. You certainly read about billions in the newspaper, but I know as smart as you are, you have no idea how big $2.8 trillion is. So I like to use a number of analogies to explain to people what $2.8 trillion really means. And this is at least one which I think is particularly effective. If you rank countries by GDP, the United States is far and away the richest country in the world at $15 trillion of gross domestic product. China's number 2 at $7.3 trillion, although if you listen to the presidential debate, you know they're currency manipulators. So you can't rely on that $7.3 trillion. Japan's number 3, Germany's 4, and France is 5. $2.78 trillion is what they spend for everything in their economy for 66 million people. That's all that great French food, wonderful Bordeaux wines, those great vacations in the Riviera, those crappy Peugeot cars, everything. That's what they spend. And we're spending that just on health care in the United States. In other words, the American health care system is the 5th largest economy in the world. Yeah, that's pretty sobering. Everyone always takes a breath after that. It's just unfathomable how much we're spending on health care. This is as I like to tell my students at the University of Pennsylvania, this is the most important slide in health policy. And we usually spend the whole 45 minutes just on this slide alone. There are many things you can understand from this slide. On the x-axis is how rich a country is. That's the GDP per person. And the y-axis is how much the country spends per person on health care. Now just focus on the line. You can see it's an upward sloping line. The richer you are, the more you spend. As a matter of fact, the more you spend increases. That's what the upward slope is. That is typically characteristic not of food or clothing, basic necessities. It's actually characteristic of diamonds and Rolls Royces, luxury goods. The richer you are, the less you spend on basic necessities and the more you spend on superfluous luxuries. So you might want to try to recalibrate. Healthcare behaves more like a luxury than it does like a basic necessity. Interesting. And you can see how many countries fall on that line, and I can actually have thrown in many more European countries, developed countries, Australia, New Zealand, Japan, South Korea. They all fall on the line, except one. That line is planet Earth, and we are off planet Earth. We are in outer space. We are, in fact, about $600 or $700 billion off that line. The most important fact for me about this graph is the fact that we could control healthcare costs. We could reform the American healthcare system without the need to ration. No responsible health policy expert, no responsible health economist would say, oh, Switzerland, they ration care. Switzerland's on that line. We could get down to that line without the need to ration. So if someone says, oh, you're going to reform the American healthcare system, that's going to lead to rationing, not necessarily. We do not have to have rationing if we reform the system. It's also important that it's not just how much we spend, but it's how much it grows year upon year. Every year, it grows at least $100 billion more. Now, just think about what we could do in this country if we didn't spend $100 billion more on health care year after year. How it might improve our schools, the infrastructure, pay down the debt. There's just a huge number of things we could do with $100 billion. And where does that growth year on year come from? Well, if I asked you, a lot of you might have said, well, the baby boomers. Turns out aging, relatively small proportion. It will increase as more baby boomers retire and get Medicare, but it's not that much. Income growth, I showed you that graph. The richer you are, the more you spend on health care. Insurance-induced demand. Economists call this moral hazard, right? You give people insurance because you want them to use health care when they're sick. But we also know that if you give people insurance, it effectively lowers the price that they see for health care, and they're going to spend more, right? Basic economics. Lower the price, people demand more. Healthcare productivity. Turns out doctors and nurses are among the least productive members of American society. Might surprise you. In fact, productivity, unfortunately, in the American healthcare system has actually been going down. We're getting more doctors, more nurses doing the same and doing work and actually getting the same output, the same amount of health. It's a paradox of the system. Administrative costs, we have a very complex system administratively. Part of that is because we're a federalist system and health insurance is regulated at the state level, and so insurance companies have to go through different states. Part of that is Medicaid is done at the state level. Part of that is we just have a lot of paperwork because we have all these different payers, Medicare and Medicaid and all these 1,000 or so private insurance companies. So that adds. Defensive medicine and medical malpractice actually doesn't add anything. Might surprise you. Certainly surprise the doctors if there are any in the audience. It's all about technology. 40 to 65% of healthcare cost increase year on year, all to do with technology. Now, some of that technology definitely is good, cures people of diseases that were incurable before, but some of it is a lot of fancy-dancy razzmatazz that actually doesn't improve health. For all that additional money, we should hope that the quality of our system were better than the Europeans. After all, we're spending $600–700 billion more than they are. And it is true, we have great institutions, many in this city, that provide outstanding quality of care. But we also have a lot of valleys, quality that we should not be proud of. The fact of the matter is, our healthcare system, when it comes to quality, is very inconsistent. And even if you're well off, you cannot be assured that you are going to get high-quality care. Yes, you can pick your doctor. Yes, you can pick your hospital. But you can't pick whether you're going to get a hospital-acquired infection in your hospital. You can't pick whether there's going to be a medication error. And so even if you're well off, you're subject to many of the vagaries of poor quality of the system. This is one graph, similar to the graph I showed you before. It's how much you spend on health care per person on the x-axis, and the y-axis is life expectancy at birth. And again, it's not as tight, not as compact as the previous slide, but you can see most of the European countries fall on that nice graph. Some of them are actually doing quite well. Japan up there doesn't spend too much in life expectancy over 82 years. CHE is Switzerland. They also are doing pretty well. And you can see the United States is doing pretty badly. Well, a lot of experts in demography or epidemiology will tell you, life expectancy at birth, that is not a good measure of the quality of a healthcare system. For one thing, we in the United States try to save these babies that are 24, 25 weeks old. They'll die at a very high rate. That'll lower life expectancy. Second of all, they say, we have a large problem with teenagers. They get into a lot of accidents. There turn out to be a lot of violent deaths, shootings among teenagers. And there's a very high, disproportionately high suicide rate in America. So our teenage mortality is very hard. That'll bring down life expectancy at birth. But it's never clear to me why we shouldn't count those things as part of the healthcare system. The mental health issues associated with suicide, murder. In any case, you don't like those numbers? I got other numbers for you. If you take people when they hit 65 and look at their life expectancy, it turns out the United States still doesn't do so hotsy-totsy. In terms of men, we're 12th, women, we're 16th, and by the way, the French are number 2. In 2006, there was this very well-known study in the medical literature by the RAND Corporation. They went to hospitals and looked at seniors who were discharged from the hospital and assessed 9 simple interventions, each of which is proven to improve health and longevity. Things like, was blood pressure measured, and if it was consistently high, was a person put on the medication to lower it? Was cholesterol measured? If it was high, were they put on the medication to lower it? If they came in for a community-acquired pneumonia, did they get a vaccine before going out and recontracting? And it turns out, overall, when they looked at these 9 measures, and I want to emphasize, these are really simple measures. They're not complicated chemotherapy like I gave, or complicated surgical procedures. This is simple stuff. About a flip of the coin, 55% of the time. And when they redid that study for children, it was 46% of the time they got proven care, like vaccines and other interventions. We're just not doing healthcare well or consistently. Here's another example, adult asthma. The U.S. has the second highest rate of adult hospitalization for asthma, twice the average in other developed countries. OECD is 34 developed countries. And our mortality rate is 5th. Nothing to be proud of. And this, I think, is the most embarrassing slide there is. Some of you may remember that in the campaign, when a lot of things are said, not all of which are true, a candidate said, well, no one in America dies because they don't have health insurance. They can always go to the emergency room. Flat out false. Simply untrue. So this slide is the 5-year survival of patients with cancer, stratified by whether they have health insurance or not. And what you can see is that if you have private insurance, and this is all cancers, lung cancer, breast cancer, prostate cancer, colon cancer, if you have health insurance, your chance of surviving are about 78% if you have private health insurance. On the other hand, if you're uninsured, your chances are down around 65, 63%. Now let me tell you, if I had a drug that could improve your 5-year survival for cancer 12%, I'd be on the front page of the Times, every TV station, they'd be talking about a Nobel Prize. And here it's about insurance. Yes, people actually die because they don't have health insurance in this country. And so someone says, well, they don't show up at the doctor because they don't have insurance. Or they show up too late and we can't cure their cancer. All of which is true. But in fact, it's even worse than that. If you take people who show up with the same kind of cancer, what we call stage of cancer, either early stage or late stage, still makes a big difference whether you have private insurance or no insurance at all. The system is not working for everyone. And yet we do many high-tech things. Compared to the average of developed countries, twice as many knee replacements. What is it? You know, our sidewalks are worse or harder than they are in Europe. 2 times as many cardiac catheterizations, 1.4 times as many CABGs, cardiac stents 1.5 times, C-sections 1.4 times, cataracts 3 times as many, CAT scans twice as many. As a matter of fact, we do more CAT scans than any other country in the world. We have more MRI scanners than any other country in the world per person. Why have I emphasized over and over again the cost issue and then its impact on quality? Not because I'm an economist, but because that cost issue has very serious consequences that I don't think most people understand. One of the reasons we have so many uninsured, 50 million people uninsured, is a direct result of our high costs of care. You know, have you looked at the University of Illinois' tuition? Up. A lot of that has to do not with bad management down at Urbana, professor salaries, the fact that professors aren't teaching or whatever, has to do with Medicaid. We'll talk about that in a second. Wages, we've had wage stagnation for 30 years in this country. Has a lot to do with health care. So let's just talk about that for a second. Here's a budget director from Arizona reporting on their situation. No different than the situation we have here in Illinois or any state. Medicaid and other health care expenses are predicted to grow as much as 40% of the state budget by 2015. That'll force the state to cut higher education funding because there are few other options. It certainly seems to be on a collision course. You know, if Medicaid keeps going up and up and up, and you're the governor of a state, you could raise taxes, oh really? Or you could try to cut your Medicaid program by reducing who gets coverage, who's eligible, cutting back. or you cut other programs that you have control over. And the one that you have the most flexibility over is higher education. And so most universities, they're called University of State, they're getting 5, 7, 9% of their budget comes from the state. Most of their budget no longer comes from the state. And the state portion has gone down and down and down. And they have to raise tuition to make up the money and do many other things. So you want to know why the University of Illinois tuition is going up and up and up? Think Medicaid, because that is the fact. And why does Medicaid costs go up? Because healthcare costs are going up. They're just linked. As I said, over the last 30 years, health insurance premiums have increased 300% after inflation, tripled. Corporate profits have increased 200% after taxes, and net worker income in private industries has actually gone down. This looks at cost changes over the last 30 years, since 1982. The triangles at the bottom are the change in hourly earnings for average American workers. And you can see basically fluctuating around zero without much change. The circles are change in healthcare costs per person. And you can see they're up at 5, 6, 7, 8%. Now, the important thing here is, in the mid-1990s, when healthcare costs are going down, with a 1 or 2 year lag, you see wages actually, for the first time, really going up to the 3% rate. And then as soon as healthcare costs increase again, towards the end of the 90s, wages then drop down. Why is that? Because as healthcare costs go up and up and up, employers hold down cash wages because total compensation is shifting more to benefits, more to healthcare costs. And one of the reasons we have had this flat middle-class earnings over the last 30 years is the fact that healthcare costs have gone up and up and up, eating up all that increase in productivity from workers. If we want to do something about the middle class in this country, we have to do something about healthcare costs. And finally, everyone's talking about the fiscal cliff. The long-term future of this country, to prevent us from turning into Greece, is all about healthcare costs. My old boss, when he was head of the Congressional Budget Office, said Medicare and Medicaid will rise from 4.5% of the economy today to 20% of the economy by 2050. This is the central long-term fiscal challenge facing the United States, period. You're going to hear all this talk about the budget beginning Wednesday. Some big budget deal is going to happen to prevent us from falling off the fiscal cliff. Let me tell you, behind all those numbers, there are only two variables that count. Taxes, what are we going to do to increase revenue, and how are we going to control healthcare costs? It's the only two things. And if we don't get healthcare costs under control, we are going to lose our world position and look more and more like Greece. Well, we've been trying to reform the healthcare system for 100 years. Teddy Roosevelt began campaigning for universal healthcare coverage in 1912. Dropped off the debate because of World War I. Universal coverage was associated with Germany and Bismarck giving coverage to the workers there. And anything tainted by Germany was suspect in World War I. In addition, and this may surprise you, American labor movement. Samuel Gompers, head of the AFL, was against the government getting involved in health care because he thought he could get a better deal from employers. In 1936, when FDR was considering and introduced legislation on Social Security, actually initial ideas was to combine it with health care. He stripped out the health care coverage part because he thought that would sink. It wouldn't pass and would sink his Social Security bill. 1946, for 3 years, Harry Truman went around campaigning for universal health care coverage, probably the president most committed to it. Defeated by the AMA, who hired the first political PR firm called Whitaker and Baxter, who came up with the very felicitous phrase, socialized medicine. Universal health care coverage, that's going to be socialized medicine, and they defeated it. Interesting how that phrase sticks around for 70 years. Lyndon Johnson tried. He got Medicare and Medicaid. Big changes, but not universal coverage. How do we know? We have them today. We still have 50 million people uninsured. Ironically, Richard Nixon. Here was a guy who was committed to universal health care coverage from day one as a politician. It might surprise you. It certainly surprised me when I learned this. In 1947, his first term in Congress, he introduced a bill for universal coverage in the United States, nonprofit entity to provide insurance with government subsidies for people who couldn't afford to buy it. Sound familiar? 47. He was for it in the 1960 campaign. And in 1973, he and Ted Kennedy and Wilbur Mills struck a deal that they were going to have universal coverage. That happened to be sunk by a couple of scandals. Some of you may be old enough to remember Fanny Fox, the exotic Argentine dancer who fell out of Wilbur Mills' car into the tidal basin. And then quickly thereafter, by the Watergate scandal, universal health care coverage went up in smoke. 1993, Bill Clinton tried, and we know what happened there. And then March 23rd, 2010, this photograph is taken right over my head, the president signing the bill. There's many, many famous people here. I won't embarrass anyone by asking who they are. I'll just say two things. I've always wondered what Joe Biden was saying to that little kid that we can't repeat. And that guy with the purple shirt and white tie, right? We got a bunch of congressional people here, senators and congressmen all who were heavily involved in health care reform. Who the hell is the guy with the purple shirt and white tie? He's not a congressman, he's not a senator, but he's the guy closest to the president. And no one knows who he is. Go figure. Well, when it comes to health care reform, I'm a real optimist, and it's not just because I worked on the bill. By 2020, undeniably, the American healthcare system will be much better than it is today. The Affordable Care Act can't take credit for all of it, but the Affordable Care Act is a key catalyst in galvanizing change in the system and driving positive change in the system. Why can I be confident in saying that it will be much better? Well, first, let me, as Al Haig once said, caveat that statement. I said 2020. You have to get the right time perspective. It's not tomorrow. And the transition between today and 2020, I didn't say it was going to be easy. We're trying to change the fifth largest economy in the world. It's going to be rocky. It looks from the audience here, many of you who have had teenage children, you know things can be rocky, but by the 20s, things smooth out a little bit. Same thing's going to be true of the American healthcare system. The next decade's going to be rocky, but by 2020, things will smooth out. Why can I be confident? Well, first of all, thanks to the Supreme Court, by 2020, we'll have this structure of exchanges, Medicaid, so that all Americans will have access to health coverage. That doesn't mean all Americans will get health insurance. Some people will resolutely stay out of the system. Ron Paul will never get health insurance. But we will have a structure where everyone can get health insurance, either Medicaid if you're under 133% of poverty, roughly $30,000 for a family of four, or in the exchanges where you buy coverage, private insurance, with subsidies from the government if you can't afford it. Big advance. Cost. We are going to try a variety of payment models to move away from fee-for-service medicine, to get doctors to more focus on keeping people healthy rather than simply more and more treatments, even if they don't make a difference. And I'll talk about why I'm very confident we're going to shift the system. We'll have more coordinated care, especially for people with chronic illness, because that's the key. And we'll have less unnecessary services being given to people. On the quality side, the vast majority of Americans will have interoperable electronic health records. We're in the baby steps now, but by 8 years from now, it'll be very, very different. We'll have more information about the effectiveness of various treatments, which patients they work well for, which ones they don't. We'll have more information about physician and hospital quality performance. We'll actually know quantitatively, is the Mayo Clinic really the Mayo Clinic? Where does it perform well and where is it maybe not so hotsy-totsy? And last, we will have fewer medical errors, including fewer hospital infections, fewer medication errors, fewer chances where the sponge is left in a patient after surgery or the wrong limb is sawed off. All of this is pretty much guaranteed, which is why I can be confident that by 2020, the American healthcare system will be better. So I want to spend time on what I think is the key driver that is going to be both essential for reducing healthcare costs and improving the quality of care. And that's how we change how doctors deliver care to you as patients. This is the second most important slide in health policy. And once you understand this slide, you can now teach my course. So let me draw your attention to your right, the little itty-bitty bar there. And that says that half the American population is basically out of the healthcare system, uses 3.2% of all healthcare dollars. Half the population. Who are they? They're not here in the audience. They're young kids, right? They're kids, they're adolescents, they're 20-somethings. They might break a bone, they might need some stitches, they might need, a strep throat swab and some antibiotics, but they're essentially not using a lot of healthcare services. And then there's the third bar. That says that 10% of the population uses almost 2/3 of the dollars. And when Willie Sutton was asked why he robbed banks, he said, that's where the money is. You got to focus on the 10%. That's where the money is. And it's also where the bad quality is. And who are those 10%? They're people with chronic illness and multiple chronic illnesses. They're people who are in the system, people with heart failure, with diabetes, with asthma, with cancer, with emphysema. So the key to saving money is prevention. Now, you might be thinking, prevention, oh, that's vaccines, it's cancer screening tests like mammography or colonoscopy or pap smears. I don't mean that kind of prevention. That's primary prevention. That's preventing people who are healthy from getting sick. I'm talking about tertiary prevention, preventing people who have chronic illness from getting sick. Keeping those people healthy means that they don't go to as many specialists, they don't go to the emergency room, they don't get admitted to the hospital. That's the key to saving money long term. And the question is, can we do it? And the answer is definitely yes. And I'm going to give you some examples where that's been done. So Arnie Milstein is a professor now at Stanford. He was a consultant when he wrote this paper in 2009 at Mercer. And he basically went to a bunch of insurance companies. He says, give me the practices. Identify for me those practices that are above average in quality and 15 to 20% below in cost. And they gave him a bunch of names, and he sifted through the names and did some preliminary research and focused a qualitative study on 4 places. Urban Medical Group in Boston. It's actually a group I worked with when I was an intern more than 20 years ago. We used to call them urban guerrillas. They're a bunch of hippies who decided to commit themselves to improving the care of people in the inner city in Roxbury and Dorchester and Boston. Leon Medical Centers in Florida. Redlands is in Northern California. I'm going to focus on CareMore Medical Group, which I have been wildly impressed by. CareMore now has 30 care centers across the Southwest. They started in Los Angeles. They spread to Arizona and Nevada. They take care of 70,000 seniors who are on the Medicare Advantage program. That's the managed care part of Medicare. And they've changed how they deliver care. First, they changed the structure. They have a care team. It's not one doctor, one patient. It's a whole team. Doctor, nurse practitioner, care coordinators, health assistants. They have specialized clinic for recurrent problems. So a doctor who sees this problem once a week or twice a week doesn't deal with it. These are for things like wound infections for diabetics, which have a tendency to get infected if they're not taken care of. They have one fantastic nurse. All she does is diabetic wound care to make sure they're pristine and don't get infected. Or blood thinning. It's called Coumadin to doctors, to make sure the blood's thinned right. They have SWAT teams for specific problems like depression and dementia. Rather than refer a patient who has depression to a psychiatrist and wait 3 months before they get an appointment, they have a SWAT team of psychologists and social worker and others to see that person within 48 hours. And they work with selected efficient specialists. Rather than sending a patient just to any specialist or the specialist they want, they work with a specialist and make sure that the specialist is familiar with the practice pattern of the primary care doctor, and they work closely together to coordinate care. They've also expanded their care. Someone who has their electronic medical record and knows the patient's diagnosis, their medications, when they were last seen, what the care plan is, available 24/7. So they don't have to just send a patient to the emergency room for evaluation. They screen patients for psychiatric conditions that are associated with high cost, whether it's depression or dementia or anxiety. They proactively monitor physiological risk factors. So if you heart failure, they monitor your weight every day. And if it's going up, they intervene before you get sick enough to land in the hospital. Or if you're a diabetic, they monitor your glucose. Or if you have emphysema, they monitor your pulmonary function. And they don't wait for the patient to call. They proactively go out and say, well, what was your reading today? And they use a lot of data-driven tools to facilitate tracking patients over time, to see how their doctors are doing, that they're actually adhering to the guidelines. And they have a lot of specialized programs, a diabetes care program, the end-stage renal disease program, a high blood pressure clinic, clinics for people with emphysema, fall prevention program. And they do a lot of maintenance therapy, exercise and strength training for people who might fall to prevent hip fractures. They have home care, mental health programs, as I mentioned, for depression, social services, podiatry, hospice, palliative care, wellness programs. Look at this, transportation. Why do they run a car service? This is a health system. Well, you've got people with multiple chronic illnesses. Getting in to see the doctor can be tough. And if you don't get in to see the doctor, the next stop could be the emergency room and a hospitalization. And you avoid an emergency room visit and a hospitalization, you can pay for a lot of car services. Let me talk about their cancer treatment. And this, they've begun to change. This is in the midst of a major change, all born because one of their senior doctors' parents got cancer, and he's seeing everything that goes wrong. He actually got cancer here. He was seeing everything that goes wrong with this major illness. First, in most cancer care, little emphasis on psychiatric counseling and care, even though we know about 1 in 5 cancer patients have depression. Treatments, wait weeks and weeks before you get that surgery, weeks and weeks before the chemo starts. And patients and families are rarely given a comprehensive overview of their treatment and the data in which to guide their decision making. So what do? Every newly diagnosed cancer patient sees a mental health professional before they go to see a cancer doctor. They're screened for psychiatric conditions that are known to increase costs. And patients and families are given a number to call anytime they experience a symptom like anxiety over what's happening. After a tissue diagnosis, that is, they diagnose that it really is cancer, they eliminate the wait time that caused families and patients unnecessary stress. An MRI and a PET scan, this is a technical scan that's used, are done within 72 hours. So there's no wait, or limited wait. They show patients and families evidence-based data detailing the treatment that they're going to recommend. They make sure patients know what the normal side effects are and the reactions to the treatments are so that they can anticipate and they don't go to the emergency room unexpectedly. So they've reduced their admissions for normal symptoms like vomiting, diarrhea. And they provide easy and immediate access to someone who can manage their symptoms 24/7. What's their result? Hospitalization rates, 24% below average. Hospital stays, 38% shorter because they can send patients home with extensive home care. Amputation rates among diabetics because they take care of those wounds so well. Fewer patients get gangrene, fewer patients need amputations, 60% below average. And overall member costs, 18% below the industry average. They're saving 18%, 18 cents on every dollar. Well, you might now begin to think about why one of the 5 largest for-profit healthcare companies just bought CareMore last year for $800 million. What does that tell you about where the health insurance industry is going? They're moving more into delivering care and delivering it efficiently and with high quality. WellPoint is now planning to launch January 1st, they're launching CareMore in Brooklyn, New York, Richmond, Virginia, and Atlanta. We're hoping to study how easy is it to reproduce this in a new place. Let me give you another example, because one's only an anecdote. Sacramento, California. CalPERS is the California Public Employee Retirement System. They are basically the big pension fund for California public employees, and they provide insurance and health care benefits to retirees. They have more than 40,000 members in the Sacramento area, the capital of California. And one of the problems in Sacramento is there are only 2 hospital systems, and one is really dominant, and the one which is really dominant just has sky-high prices and really, really takes advantage of the situation that they have a near monopoly. So Calpers wanted to lower their costs. They went to that hospital system and said, you know, can we come to a deal where if we lower costs, we share the savings with you? And the hospital system says, we're doing well here. Why would we do that? No way. So they went to the other one, which was Catholic Healthcare's West, and they struck a deal with them. They collaborated between the insurer that they used, Blue Shield of California, Catholic Healthcare West, and a multi-specialty group of doctors called Hill Physicians. They didn't merge or anything. They didn't form some complicated unit. But they collaborated on clinical and case management and to try to coordinate care, and they all shared if there were savings. So by sharing data, the three organizations were able to identify unnecessary high-cost items that they could eliminate. First, they reduced overuse of things like hysterectomies and elective knee surgeries. High use, often unnecessary. They reduced their readmission rate. Many of you will know that in the Medicare program, your chance, if you've been discharged from a hospital, of returning to a hospital in 30 days is 20%. 30 days, 20%. Just imagine if you took your car in for repair, right, and 1 out of 5 times you had to take it back within 30 days. You'd go bonkers. And then they reduce out-of-network care. So if a patient went to a specialist who had no affiliation, they had no reason to be cost-sensitive and to try to be efficient. What were their results? First year, 15% reduction in inpatient readmissions, 15% decrease in inpatient hospital days, 50% decrease in long hospital days. They saved $15.5 million for over 40,000 patients. That's $400 per patient. 1 year. Second year, $37 million. They added $22 million savings. So they got year-on-year savings. Pretty impressive. I want to end the talk tonight by talking about the ethics of the mandate. Now, many of you will know that the constitutionality of that issue was settled in June, although settled somewhat mysteriously. To this day, no one has any idea why Roberts voted the way he did and what motivated him really, whether he really switched his vote at the last minute. No one fully understands that, and it may be that we'll all go to our graves never fully understanding it. I was actually on the podium with Paul Clemente, who's the lawyer who argued the other side, saying that the mandate was unconstitutional. And he says, you know, he's talked to a lot of people who still has no additional insight into the decision. And if you read the decision, it's also a bit of a mystery from a legal perspective, why he spends all this time telling you why this reasoning won't work and that reasoning won't work, but the taxing clause will work. But I'm not a lawyer. I'm an ethicist. And I think that separate from the law, there is a very good ethical justification for a mandate. So let's begin by thinking away from healthcare. Individuals have a moral duty to rescue other people in urgent need, at least when doing so involves minimal risk and burden. So if you see a little kid who's in harm's way and it's not going to put you in harm's way to save them, right? You have an obligation to go over and do that. And we would condemn someone as irresponsible, morally irresponsible, if they didn't do that. Well-known, well-accepted moral duty. In the healthcare scenario, we've actually embodied this moral duty in a law called the Emergency Medical Treatment and Active Labor Act, called EMTALA. And that basically says, look, hospitals, you're required to provide emergency medical care regardless of the insurance status if someone shows up in your emergency room, either for an emergency or to deliver a baby. Once you've stabilized them, then we can find out what the disposition is. But you can't find out their insurance status or can they afford it before you give emergency care. You have a moral duty to care for that person. And by the way, we've now made it a legal duty. Think again about this away from the healthcare setting. It's not just the people rescuing that have a moral duty. There's actually now a moral duty on the rescuee, the person in danger. So in 2011, there was a massive earthquake in Japan. You know, right? It created all that nuclear problem in the nuclear reactors in Japan. But it also sent huge tidal waves across the Pacific Ocean towards California. Surfers were warned to stay out of the water to protect themselves, but also to protect the lives of any individual in the Coast Guard who would be required to save them if they got into trouble. Surfers had a moral duty not to go out and surf and take those big waves. Not necessarily to save their own ass, but to save someone who might have to risk their lives to save the surfer if they got into trouble. So here's a situation where you have a moral duty not to do something because it might put someone else in danger. Now, a potential rescuee like that surfer or like mountain climbers can be required to take rescue precautions if the chance of requiring rescue is high, the burdens of providing rescue are substantial, might endanger someone, and the costs and burdens of the precautions are not excessive. Now, if we move away from the surfer example or the mountain climber example, and we move to the insurance situation, you might say, if you're uninsured, and there's a high chance you'll require medical care, the burdens of someone giving it to you are high, and for you to get health insurance is not that burdensome, then you probably have a moral obligation to get that insurance. Well, I think that holds in the healthcare setting. Everyone is at substantial risk of needing care, even young adults. While in general they don't use a lot of health care, who knows when you're going to be hit by a car, or God forbid get cancer, or some other illness that is unpredictable. 52% of 18 to 29-year-olds are overweight and obese and might need health care. 15% of 18 to 29-year-olds have asthma, arthritis, cancer, diabetes, heart disease, need health care. There are 2.34 million live births to mothers 18 to 29. You certainly need health care. Young adults, a quarter of them every year receive emergency room care. Now, it may not turn out to be wildly expensive in any individual case, but many of them can't even afford what it is. Routine acute and emergency care can be expensive. An appendectomy, on average, over $15,000. The average cost for delivering a newborn, $10,000. For vaginal delivery, $21,000 for a C-section. Unless the uninsured individuals pay out of pocket or incur debt, they're basically transferring those costs to the rest of us, right? Hospitals, clinics, they have to absorb those costs, and what do? They basically jack up the prices for people who have insurance, right? It's a cost shift. In 2008, it's estimated that uncompensated care was over $57 billion. Well, I grant you, in the scheme of $2.8 trillion, not a huge amount, but in the scheme of normal life, $57 billion is more than pocket change. Right? About 75% of that was paid by federal, state, and local funds appropriated for care of the uninsured. Now, for low-income Americans, purchasing health insurance would force them to forego essentials. That's true for many people. Health insurance is pretty expensive. But that's not true for everyone. And federal subsidies in the exchange, going up to 400% of poverty, can help people buy insurance at an affordable rate. Here's actually broken down the uninsured in America by income, if you look at the bar graph. And what it shows you is that actually 10% of people who are uninsured make more than 400% of the federal poverty line. And for those of you who don't keep the federal poverty line at the tip of your tongue, that's round about $90,000 for a family of four. They're by no means poor. Now, there are probably good reasons they're not in the insurance market, even though they're making that money, right? They may not have an employer who offers it. They may have to go into the individual markets. Someone in their family might have a pre-existing condition that makes insurance unaffordable. Some of them might be slackers. Similarly, 13% earn 251 to 399% of the federal poverty line. That's around $55,000 to $90,000. Now, I'm not saying those people can all afford it without some help, but again, the health care reform law has subsidies to help these people. So it's ethical to require people to have insurance that covers at least emergency care if they would receive because of the moral duty to rescue, right? If I've got a moral duty to rescue, they have a moral duty to have health insurance to pay for that rescue, and care that they're likely to need in a high probability situation. Now, this may not require them to get comprehensive health care, private insurance, but I think it does require people, it does justify, from an ethical standpoint, a mandate to get at least minimal coverage. So let me conclude overall. Healthcare reform, the Affordable Care Act passed in March 2010, was a world historical event. We've been trying for this for 100 years. As I said to you, it will dramatically improve American healthcare. The road ahead is going to be bumpy. All transitions are bumpy, especially if you're trying to transition $2.8 trillion economy. But by 2020, things will quiet down. We'll have a structure in place. We'll have normal operations. And it will guarantee that every one of us get better coverage, better healthcare system. Coverage is going to be improved because we're going to have a system that allows everyone to get either Medicaid or private insurance or Medicare. We're going to try a number of new payment methods to incentivize more coordinated care, less unnecessary tests and treatments, keeping patients healthy, doing what Care More and that Sacramento ACO do. And reduce unnecessary services, improve the quality of care, reduce the need for hospitalization, and saving money. And we're going to have better quality. Americans are going to have electronic health records. We're going to have more information on the effectiveness of medical interventions, fewer hospital-acquired infections, fewer other errors, more monitoring of quality done by hospitals and doctors, and more coordinated care. We are going to have a better healthcare system for all of us. Thank you very much, and I appreciate your attention. Look forward to your questions.
At this time, we'll open it up to the audience. We have time for one or two questions when we have a mic on each side of the room. So I see one right back here.
Dr. Emanuel, excuse me, you recently wrote a piece in New England Journal of Medicine talking about Medicare reform. Could you please tell us what would be some good starting points to reach some common ground on that subject?
Yeah.
Thank you.
So we called together, I think, 24 leading experts from both sides of the aisle, health experts, people who run health plans, as well as people who've thought about the issue, health economists, people who've run Medicare. And we came up with 11 different proposals. I'm not going to go through all 11, but let me highlight what I take to be the top three. Top three, not because necessarily they're going to do the most, although I do think they will do a lot, but top three because I think they can get bipartisan support and they will get us far down the line. So number one is payment reform. We have to change how we pay doctors. 80% of doctors, or 80% of payments, are now made in what's called fee-for-service. Doctors get paid for doing more. You know, if you're a surgeon and you get paid fee-for-service, you get paid if you operate. Ergo, you operate. We need to change how we pay doctors. So what we proposed is that sort of three-step process. First, the government says that in 10 years, by 2022, 75% of payments will no longer be fee-for-service. You have to get off this system. Two, to begin that process, we urged Medicare to introduce what's called bundled payments, or payments for the whole treatment process for orthopedics, hip and knee replacements, and for cardiac procedures, stents, bypass surgery, catheterizations, pacemakers. Government's already tested this out, shown that it improves quality and can save money. We said, roll that out nationwide. Don't wait. There's no reason for more tests. As a matter of fact, the Congressional Budget Office says these bundled payments are our best opportunity to save money. So we said, let's roll that out. I can give you lots of reasons why I think that's the best place to start. Those are procedures people make a lot of money on. They involve not just surgeons, but medical doctors and radiologists and anesthesiologists in hospitals. We said second, Or third, set a time course, start out with these bundle payments for cardiac and orthopedic procedures, and say that by 2017, 5 years from now, you're going to do 2 chronic conditions. We recommended cancer and congestive heart failure because they're very big and very expensive, but also there are good guidelines by professional doctors as to how to treat these patients, and introduce them by 2017. This will transform, again, this is how you motivate doctors to care for patients to keep them healthy and not just to do more. The second thing we said is, let's do more of what's competitive bidding. Right now in Medicare and Medicaid, the government does a lot of price setting. They said, all right, we're going to buy a wheelchair, we're paying X dollars for a wheelchair. Or we're going to buy an artificial arm, we pay X dollars for an artificial arm. Well, most of us think, first of all, price setting is more socialist than capitalist. And the government is never good at being a price setter. And prices don't tend to change by the market. Why should we have government price setting? Let's have the market do it. So we should introduce competitive bidding. Now, we did introduce some competitive bidding in the Affordable Care Act. We actually introduced competitive bidding for wheelchairs and beds and other medical equipment. We introduced it for prosthetics. We introduced it for orthotics. But it takes some time to roll it out according to law. The first year we tried it, 42% savings in Medicare for those items. So we said, look, let's go national now. Why wait? First. Second, what about all the other things that are really just commodities in healthcare? And there are a lot of them. Those lab tests you get, you know? Ever seen what's on the back end? They're these big machines. Every company has the same big machine. And big machine is basically automated. Or CAT scans. Not the reading of the scan, which takes a lot of technical expertise, but the actual scan itself. These machines run themselves virtually. We could have competitive bidding for those to bring down the prices. Government should not be setting prices for these things. The third thing we recommended is price transparency. You know, anyone have any idea what the cheapest place with high quality is to get a colonoscopy in this town? You know? Or if you need a procedure, I needed a procedure on my hand to relieve a trigger finger. You know what the various hand surgeons are charging and what their performance is? We need more transparency on prices for things that aren't emergencies and on the quality of activity. And we think the government should require that. And there are, by the way, lots of insurance companies with hospitals especially have what are called gag rules. You can't say what you're being paid. Get rid of the gag rules. If you want a market to work, you have to have information. The fact that we don't have information is one of the reasons the healthcare market doesn't work. So those were 3 of 11. The last one, which is a little unusual for a group, was that we needed malpractice reform. Now, we didn't think we needed malpractice reform that's been commonly proposed, which is limit the caps on non-economic damages or pain and suffering, shorten the statute of limitations so it's only a year. We thought we want to use malpractice reform to encourage better quality care. So we proposed what we call safe harbors. If you follow an approved guideline, if you have an electronic health record, you have a built-in decision support, you ought to be presumed, it's a rebuttable presumption, but you ought to be presumed that you were doing quality medicine. Now, the plaintiff would then have to show either they didn't qualify for, you were following the wrong guideline, or you really didn't follow the guideline in their case. But the presumption, so the barrier would be higher if you could show you were following the guideline and you use electronic records to ensure adherence. We think that would encourage exactly what we want, which is to get rid of the bad cases, to get rid of the errors, rather than just to be punitive about how much can be settled for. So those were 3 or 4 of the proposals. Wait, do we need a microphone?
So you have discussed many ideas to make significant improvements to the system. The question that I have, and it's something that you didn't discuss, is what I would call more revolutionary approaches to deliver healthcare. And so that are also not kind of that different. But for example, I had an experience in Kaiser in California, and they seem to have a much more integrated approach to deliver healthcare than a great private insurance that I have here, but that requires basically a lot of running around and seeing people in different places. The prescriptions, instead of just going downstairs at the hospital and picking it up, I have to go to Walgreens, or if they change to a different person and so on. And so I don't know if you have some thoughts about really not trimming around the edges, but where should we go in the medium to long term?
Actually, the delivery system reforms, CareMore and that Sacramento ACO, are moving in a much more coordinated direction, actually in some cases doing more than Kaiser is doing to actually provide higher quality care. Kaiser is one model, and it worked. Many people are very happy with it, but there are many other models. I don't think there's a single right model. I don't think we know the best of all the worlds. I actually think, in point of fact, what I presented is where I think the future is going. And some of these organizations are doing things even better than Kaiser has been doing. So.
And this will be the last question, one more.
All right, we didn't get anyone from the front. I think it's a little unfair. That's an ethical issue. Yeah.
We'll come to you.
Having practiced medicine in 3 or 4 countries,
Yeah.
including countries in Europe,
Yeah.
I agree with your findings 100%. I think the cost of health care in this country is absurd. However, you failed to mention the advanced technology and the pharmaceuticals, and you put all the blame on the doctors, though they get only 14 to 16% of every dollar spent on the healthcare industry. And I think medical education has to be restructured and reorganized.
So first of all, I hope I didn't blame the doctors. I actually didn't point a lot of fingers. And I don't like to point a lot of fingers. I don't like to point a lot of fingers at the drug company or the insurers or the doctors or the hospitals. We're all in a bad system. Most of the people I've met in all those industries, they're really smart, they're well-intentioned, and if they're doing something stupid or bad, it's because of the structure and the incentive structure in which they're in. And so I think it's not that, medicine or drug company, drug development or insurance companies attracts bad people. I've always asked, do you think when a big insurance company goes to either a medical school or law school or business school to recruit people, they said, give me your nastiest, your most unethical people, those are the people I want to work for me? No. But you put them in a circumstance, in a structure that perverts the incentives, you get a different bad behavior. So I think it's the structure of the system, and part of what I've been trying to emphasize is we've got to change the structure of the system, and I think the Affordable Care Act goes a long way to changing that structure. I couldn't agree with you more. I think one of the slowest changes we've had, and one of the areas we have thought the least about, is changing medical education. So I have been a little wacko, you might say. About a year ago, I wrote not even a year ago, 6 months ago, I wrote a commentary in JAMA recommending that we shorten medical training by 30%. First of all, we could get rid of 1 year of medical school, no problem. No one hurt, everyone helped. Surgical training. I was just at dinner with surgeons at NYU Medical Center, and sitting to my right was a woman who's a endocrine surgeon, operates on the thymus or other small organs that release hormones. And I said, so, do you do any general surgery? No. How long did you have to train before you became a specialist in endocrine surgery? 5 years. 5 years. That's nuts. Maybe 1 year, then specialize in the endocrine surgery. Why did she have to know how to do, an appendectomy? She's never going to do it again. Same thing for brain surgery, right? They train for 5 years on everything else but the brain. It's crazy. So we need to rethink. And then we also need to rethink what we're teaching kids in medical school. As important as, physiology is and renal function. I like to point out that in all my practice as an oncologist, I never used the Krebs cycle once. I think I learned it 6 or 7 times. On the other hand, knowing how to structure an office, use data to track patients, negotiate with my patients about taking the medicine. Really important. How much psychology training did I get in medical school? 0. All right? Very, 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 it seems to me, we really need to rethink medical education, and there hasn't been enough written about it. It's actually something I'm sort of thinking about some of my attention to. So can we have one question in front, and then we'll let people go? There's this nice lady who's been waiting.
Who's been really, who needs it? Who wants it? Who's really? Okay. This will make a difference. You're very kind.
All right. I'm happy to sit here and talk all day.
You're very kind to have let me ask my question. I work for a relatively large healthcare system in the area, and I'm wondering if you could just comment on the movement towards using hospitalists instead of primary care physicians in the healthcare system. And then secondarily, you've saved me so much time with some of the information you have because I've been seeking the golden tickets for the readmission issues. I'm wondering if you'd be willing to share your slides.
Only for a price, and you can't afford it. So one of the issues, this hospitalist issue is, in the old days, when my dad was a practitioner, you know, you would have a patient, you admitted them to the hospital because they were sick enough for the hospital, and you cared for them in the hospital. Those days are gone, and in my view, they're gone forever. It's not efficient. People lose their skills. But there's a lot of dissatisfaction also with the hospitals because the coordination stinks. I believe we're going to some extent, get over that problem. We'll probably get over it partially by having more integrated systems so the hospitals be more closely connected to the primary care doctor. But I don't see us going back to where the primary care doctor is following their patient in the hospital. I just don't see it. So we have to focus on, we are going to have people who are only working in the hospital. And we have to focus better on that coordination. That's been one of the weakest parts of our system, is how the hospital coordinates with the outpatient setting. So here are my two optimistic thoughts about that. First, fewer people are going to be going into the hospital. If, in fact, we keep the chronically ill healthy, one of the things that means is fewer people are in the hospital. And so the need for that coordination may, in fact, reduce to some extent. And the second thing is, we are going to begin thinking much more than healthcare really is about what happens in the hospital and the doctor's office. Healthcare, I mean, those are tiny, tiny, tiny parts of a person's time, even a person with chronic illness and multiple illnesses, right? It's everything else. So I think healthcare is going to go out of the hospital, partially with technology, partially with people going to patients' homes. So I think the hospital is just going to become less of a key integral part. I mean, we spent the last 70 years, really, since the end of World War II, focusing on the hospital. I think now we're going to be focusing where patients are, i.e. at home, and that's going to be much more of how do we get the care there. So it's a little bit back to the future, back to house calls and things like that. And so that, I think there's going to be a really big movement in that direction over the next few years. All right, thank you very much, and I appreciate it.